Join from this. Madam, we are live now. We will talk in this later. So, ma'am, if you allow me, then we can start the program.
Yes, we can start.
So good evening, doctors and all the participants. I, Shuman, on behalf of Shield Healthcare, welcome you all in today's session on recent advances in PCOS. And our guest speaker is Dr. Meenu, madam. And it's my honor to introduce madam, although madam doesn't need any kind of introduction. She is very well known, and it's my formal responsibility once again to introduce madam. So madam is basically ERT specialist trained in Lilavati Hospital, Mumbai, and madam is the director and consultant obstetrician in Meher Hospital, and madam is the president Uttarakhand Society for Obstetrician and Gynecologist. And in terms of award, madam I have already won this Medical Excellence Award from Chief Minister of Uttarakhand, many other awards, and a Best Doctor Award by UMA Uttaranchal Mahila Association in 2008. So with this brief introduction, I request madam to take over the session, and meanwhile I request all the participants for your active participation, and please post your queries on the QA dashboard of the Shield Connect page. So once the talk will be over, we shall have a short discussion on this topic with madam. So thank you very much, madam, once again for your valuable time in our platform Shield Connect, and over to you, ma'am, for further postings. Thank you very much.
Good evening, everyone. At the outset, I thank the Shield Pharma people for giving me the opportunity on such an important topic, which is very close to my heart: the recent advances in PCOS. PCOS, we all know it is a great mysterious disease. It involves a lot of endocrinology and the metabolic syndrome. It affects the female health, and it also affects the female reproductive health. And the changes which is associated with PCOS have a lot of endocrine and metabolic changes, which leads to health hazards. It causes infertility, it causes type 2 diabetic mellitus, coronary heart disease, endometrial carcinoma, and it causes cardiovascular disease, hypertension, and dyslipidemia. So it is a disease of mystery involving multi-speciality, creating a lot of controversy, and adding diagnostic dilemma. So before wasting any time, we will start our topic, recent advances in PCOS. So polycystic ovarian syndrome is a chronic metabolic and endocrine disorder. It affects 26% of reproductive age women. In the long term, as we have already discussed, it causes endometrial cancer, diabetes, metabolic syndrome, and cardiovascular disease. There is an increased prevalence in those girls who have a high BMI. And out of 3, 2 of the Rotterdam criteria has to be there for diagnostic, like polycystic ovaries, oligomenorrhea or anovulation. We call it anovulation or oligomenorrhea when a girl has a 8 menstrual cycle in 12 months. So when the girl is having less than 8 menstrual cycle in 12 months, we call it oligomenorrhea. And third is hyperandrogenism. We call polycystic ovaries when there is a more than 12 follicle arranged at the periphery of the ovary, and there is a hyperechogenic ovaries is present. 50 to 70% patients with PCOS have hirsutism. 50% women are diagnosed, and 5 to 10 women of the reproductive age have PCOS. And it has been found that the 30 to 75% of the PCOS patients are overweight. And 50% patient has a reproductive problems. Now the causes. The PCOS runs in the family. It has a genetic overlay and the environmental overlay. Genetic overlay is most of the time it runs in the family. There is a history of the diabetic mellitus in the family, in the bua, in mosi, nana, nani, dada, dadi, or parents. And genetic factors are beyond our control, but environment factors are our control. It has been found by the use of the plastic, by the use of the tin foods, the fetal cells have reactive stress, oxidative stress. Because of the reactive oxidative stress, there is inflammation and there is polycystic ovarian syndrome. Other factors thought to affect the pathophysiology and phenotype of PCOS include insulin secretion sensitivity, lack of exercise and activity, and persistent hormonal imbalance. We all know about this, the development of the follicle, primordial follicle at the time of the puberty, primary follicle, secondary follicle, early antral follicle, late antral follicle, and pre-ovulatory follicle and ovulation. There is a different diagnostic criteria for PCOS. National Institute of Health 1919 menstrual irregularity and hyperandrogenism is the criteria for PCOS, with the exclusion of the other etiology like androgenism and the adrenal tumor of the kidney. And second is the Rotterdam criteria in 2003. It says that the 2 out of the 3 is required for the diagnosis of the PCOS, like menstrual irregularity, hyperandrogenemia, and ultrasound polycystic ovary, with the exclusion of the other etiology. And the third is in 2016, Androgen Access Polycystic Ovary Syndrome Society. It is the menstrual irregularity plus minus ultrasound finding of the polycystic ovary and hyperandrogenemia, with the exclusion of the other etiology. There are certain phenotypes have developed. Recently, certain phenotypes have developed. Phenotype A, consists of the hyperandrogenism, ovulatory dysfunction, polycystic morphology. Phenotype B, hyperandrogenism, ovulatory dysfunction. Phenotype C, hyperandrogenism, polycystic morphology. And phenotype D, ovulatory dysfunction and the polycystic morphology. The above two, consisting of the hyperandrogenism, ovulatory dysfunction, polycystic morphology, and hyperandrogenism and ovulatory dysfunction, is a classic PCOS, and it leads to metabolic syndrome and lifelong health hazards in later stages of the life. And C and D are easily controllable. Signs and symptoms. We all know PCOS, adolescent girls who come with the PCOS have hair loss, hirsutism, pelvic pain. In reproductive age group, there is infertility. Overweight is present in the 50 to 70% of the PCOS patient. There is irregularity of the period, fatigue, depression, testosterone levels are raised, and acne is there. Ultrasound is the gold standard for diagnosis. In ultrasound, ovary size is increased. It is more than 10 centimeter square, and there is a small 2 to 9 millimeter size of follicles that present at the periphery. And it can be present in the single ovary, it can be present in the bilateral ovary. And the stroma is hyperechoic. Hyperechoic stroma is there in ultrasound finding. So this we have already discussed, and we can find the volume of the ovary by prolate epistoloid formula of volume, length into breadth into thickness multiplied by 0.513. We can find the volume of the ovary. If the volume is more than 10 centimeter cubic square, then it is said to be PCOS. PCOS affects the skin also. In PCOS girls, there is a history of the eczema since puberty, and it has been found that there is a velvety thickened skin on the neck, in the axilla, and between the breast. It is due to the high insulin level in the patients. There is an increase in hyperinsulinism. There is an increased hirsutism because of the hyperandrogenism. It has been found that the increased growth of the hair on the face, arms, legs, back, and chest. These all are related to insulin resistance. There is hirsutism is there, as we have already discussed, and there is a Ferriman Galway scale. The 9 areas are involved for scaling of the hirsutism, like upper lip, chin, chest, abdomen, pelvic, upper arm, thighs, upper neck, and the lower back. The grading is done, number is given, and the grading is done according to the amount of the hair growth. If the total score is 36, if the score is 12, it is called the mild hirsutism. If it is between the 12 to 18, it is called moderate hirsutism. And if it is more than 24, it is called the severe hirsutism. And treatment is accordingly. Now we can come to the acanthosis nigricans, which I have already talked. There is a velvety, thick, hyperpigmented skin present on the back of the neck, in the axilla, and between the breast. It is visible marker which strongly suggests insulin resistance. It is the higher than normal levels of insulin cause the darkened growth of the skin. It activates the keratinocytes receptors, especially IGF-1, and there is increased IGF present, and which may lead to the increased keratinocyte and the dermal fibrosis. Since the oocyte quality is not good, so the embryo quality is not good, there is increased chances of the pregnancy complication like spontaneous abortion. There is an increase in high BMI or PCOS. There is impaired glucose tolerance. There is a chances of twin pregnancy. There is chances of gestation diabetes in pregnancy. There are increased incidence of the hypertension, and there are chances of small for gestational age babies. PCOS is associated with the characteristic metabolic syndrome that includes insulin resistance, dyslipidemia, and the hypertension. These features are linked with the increased risk of the type 2 diabetic mellitus and possibly of premature cardiovascular disease. Certain studies was done in human reproduction. It has been found in the human reproduction book, and there is a long-term follow-up of around 800 women. There is an increased incidence of the endometrial cancer, and as studied by the Dankren et al., Acta Obstetrica and the Gynecology, Scandinavia, 1992. Cardiovascular disease, PCOS is characterized by the endothelial dysfunction and the resistance to the vasodilating action of the insulin. So it causes the increased incidence of the cardiovascular disease in PCOS patients. Metabolic consequences can be sleep apnea because of the increased BMI, because of the increased weight. There is increased sleep disordered breathing is present. As discussed by sleep medicine, and there is increased chances of the depression because of the high body mass index and the greater insulin resistance. How to manage PCOS? It is very important to know the facts about the PCOS, and we can manage PCOS only by positive thoughts, by exercise, yoga, pranayama, meditation, and diet. Positive thoughts are very important. Most of the PCOS girls are obese, and we always advise to do exercise. It is easily said that done. So we need to have a positive inspiration, positive motivation, and persistence to these girls. Because of the persistency, because of the positivity, because of the continuous inspiration, they are able to reduce their weight. And with the reduction of the weight, there is a lot of good changes in PCOS girls. Exercise is very important. We have to encourage our girls to do physical exercise. Most of the time, these girls are sitting in front of the books, or they are having eating junk foods and eating tinned food. So we have to encourage for physical exercise in these girls. Yoga pranayama is very important, and it decreases the stress. Meditation, yoga pranayama decreases the stress and improves the sleep pattern. Diet as such plays a very important role. Diet has an 80% role in improvement of the weight reduction. So one by one, we will discuss each and everything. Now, what is gluten? Gluten is a high glycemic index food. It is a sticky protein found in wheat, rye, and barley. Naturally, gluten-free foods are available in our market, like poultry and meat, legumes, fruits, fish and seafood, dairy products, beans, legumes, and nuts are there. So these are the gluten-free products, and we can take an advice to all PCOS girls. Bakery products have a high gluten content, and they are product of the high glycemic index, like bread, crackers, cereals, pasta, and baked foods. In patients with PCOS who are obese, endocrine and the metabolic parameters markedly improve with 4 to 12 weeks of the dietary restriction. If we do dietary restriction, if we follow the pyramid of the food, we stay at the base of the pyramid of the food, there is a definitely decrease in the weight. With the decrease in the weight, there is an increase in the ovulatory function of the girls. So there is a sex hormone binding globulin levels rise and the free testosterone decreases by two folds. Serum insulin and IGF and 1 levels also decrease. With the weight loss in patients with the PCOS, there is an association with the reduction in the hirsutism and the return of the ovulatory function in 30% of the women. We have already discussed about the food pyramid. This food pyramid is very important. Everyone should know about the food pyramid. If we follow the Mediterranean food pyramid, we can guide our PCOS girls, and they can easily resume their normal weight and normal ovulatory function. Every day we should be physically active. We should do walking. We should do cycling. We should do certain exercise on regular basis. Every day we should enjoy low glycemic food, and every day we should be having vegetables, fruits, whole wheat grains, olive oil, beans, nuts, legumes, seeds, herbs, and spices. And every day we should consume lot of water. And often, at least twice weekly, we should have fish and seafood, and we should have wine also. Wine is very good for health, and it decreases the lipid, it maintains the lipid profile. Weekly, we should have in moderate portions, we should have poultry, eggs, cheese, and yogurt. And we should avoid taking meats and sweets and ice cream and bakery product. So processed food has to be avoided, like chocolates, cakes, pastry, processed meals, meal replacement shakes, instant soups, cold drinks, ice cream, white flour bread, and soda containing high sugars. We should avoid them. Yoga plays a very important role in PCOS. It has been found that the certain yogas like Buddha position yoga and cat cow yoga and Dhanurashan, Surya Namaskar, all these things help to reduce the roga. It is my personal experience. One of my adolescent girl married recently, she was a case of the PCOS. Her E2 levels are 422 and her LS level was 24. And she joined online yoga classes. And within 2 months, I could not digest, I could not believe her LS level come around 8 and her E2 levels come within range, it was around 50. So yoga and meditation play a very, very important role in treating PCOS. So we can do brisk walking, stretching exercise, jogging, yoga, Zumba dancing, cycling, and the swimming. All these exercises are very important, and they may improve the all the criteria, all the parameters of PCOS. So exercise guide is we should do aerobic guides like skipping, walking, running, playing, all the cycling in 4 days in a week. And 2 days in a week, we should do strength exercise like lifting of the weight, bicep curls, crunch, lunges, and all this weightlifting we should do. Management is definitely it has to be multidisciplinary approach. PCOS is associated with the hyperandrogenism and there is a metabolic changes. There is an increased risk of the cardiovascular disease, type 2 diabetic mellitus, abnormal lipids, obstructive sleep apnea. Reproductive changes are always there. There is irregularity of the menstrual cycle. We can advise oral contraceptive pill. By giving oral contraceptive pill, androgen levels falls down and there is a regularity of the menstrual cycle. And estrogen contained in the OCPs increases the sex hormone binding globulin levels, so it decreases the testosterone level. There is psychological changes in PCOS patient, like there is increased depression, anxiety, psychosexual dysfunction, disorder eating, and the feminine identity challenge. When the girl grow, since morning, since in the beginning, since in the childhood, she used to play with the Barbie girls, and she thinks that one day she will be like Barbie girl. When she grows and she sees she's obese, she has developed hair, she has developed acne, she is under a lot of depression. So there is a loss of feminine identity. So we have to manage these girls by proper counseling and advising them to diet. There is a cognitive behavioral therapy and the psychotherapy and support group really helps. These girls need supportive system. All the girls with the PCOS, they should make a group, and so that they can encourage each other. With the supportive group, there is a definite improvement in all the parameters of the PCOS. Now we'll talk about the pharmacological management. Pharmacological management in PCOS is by oral co- contraceptive pills. Combined oral contraceptive pills can be given. It helps to control the androgen axis. It decreases the androgen levels and it regulates the period and painful periods. But combined oral contraceptive pills should be avoided in patients with high risk of the venous thromboembolism. Another pharmacological drug which we use is the metformin. Metformin is used in PCOS patients, and when our patient go to the market to buy metformin, the chemist tells them that it is a drug for diabetic mellitus. But since PCOS is associated with insulin resistance, this drug is given in those patients who have insulin resistance. It is used widely to treat type 2 diabetic mellitus. It increases in uh, it causes the increase in the insulin action in intracellular locus. It results in the decreased hepatic glucose production and it stimulates tissue uptake of the glucose. It causes reduction in the absorption of the glucose by GIT. It doesn't cause hypoglycemia and doesn't associate it with weight gain. With metformin, it is compliance is very poor. It causes belching, it causes nausea and vomiting. So there is a certain other drugs are coming in the market. They are food supplements, and they do not cause all these symptoms. Uh, Now we'll talk about the medroxyprogesterone. In PCOS patients, we have found that there is infrequent menstruation or no menstruation. In those girls, we give 10 milligram of the medroxyprogesterone for 14 days to bring down the bleeding. And depending upon the ultrasound finding, whether what is the endometrium lining. If the endometrium lining is thin, we can start with OCP pills. Or if endometrium lining is thickened, we can continue with 10 milligram of the medroxyprogesterone for 14 days. Women with PCOS who are amenorrheic are not estrogen deficient, and they do not need osteoporosis prophylaxis when taking medroxyprogesterone. It has been found in the PCOS group E2 levels are quite high in those girls. So there is no estrogen deficiency in those girls. There are 3S for PCOS hormonal balance. Stress management is very important. Chronic stress is one of the key driving forces of the PCOS. It increases inflammation, worsens insulin resistance, increases testosterone level production, and not to mention negatively impacts your emotional well-being. The stress management is very important. I've noticed that those girls working in the MNC multinational company, they have a night shifts. So because of the stress of the work, their emotional balance and their LH levels are E2 levels are quite raised. So stress management is very important. For these girls, we advise meditation and yoga. It really helps. Sleep is very important. Sleep is a master reset button for our hormonal stress. Lack of the sleep is impact your hormones, energy, hunger, craving, performance, and everything. So quality sleep is incredibly vital for overall hormonal health and therefore your overall health. Smart supplementation is very important. Calcium intake is very important. Sometimes it is very important to take myo-inositol and dichloroinositol. Whether we should take metformin or not, it is very important to take care of our PCOS. Now we will discuss the evidence-based newer approach with myoinositol. Myoinositol is a supplementation. It corrects altered LH-FSH by regulating GnRH pulsatile. It improves insulin sensitivity by acting as a secondary messenger to insulin action in the peripheral tissues. Brings down plasma level of insulin, improves ovulation and oocyte quality by acting as a secondary messenger for FSH. The ratio of the myoinositol and dichloroinositol is 40:1. It is a preferred drug in adolescent patients who are obese. Certain studies have been done by University in Rome in Italy, and it has been found that the 40:1 myoinositol and dichloroinositol plasma ratio is able to restore ovulation in PCOS patients comparison with other ratios. Now we come to the management of infertility. For management of infertility, there is a first line treatment, second line treatment, third line treatment, and then we go to the tertiary management. First line treatment is the non-pharmacological lifestyle modification. Lifestyle modification is a prime important. Diet and exercise, yoga, as we have already discussed, and meditation play a very important role. It has been found by reduction of the weight by 5%. There is an improvement in the ovulatory function. There is a decrease in the visceral fat. With a decrease in the visceral fat, there is improvement, menstrual cycle improves, there is a ovulation in reproductive age group of girls. So lifestyle modification is the crux of the management of infertility in PCOS patients. The second life management is the pharmacological management. After pharmacological management, first line is oral ovulogence. Among oral ovulogence is the aromatase inhibitors and the clomiphene citrate. These days, aromatase inhibitors is the drug of choice in the obese patient, but clomiphene citrate in every way superior to the aromatase inhibitor. And if the girl is not able to ovulate with clomiphene citrate, we add metformin. Clomiphene citrate and metformin gives a good percentage of the ovulation in girls. And metformin is given in those patients who have insulin resistance. If we do not get ovulation with clomiphene citrate and metformin, then we switch over to gonadotropin. Gonadotropin is a drug which is given for the ovulation, but with gonadotropin we have to be very careful. Careful monitoring is required for follicular development, to see the development of the ovarian hyperstimulation syndrome, and to see whether there is a multiple pregnancy or not. And the third is surgical management. Surgical management is by laparoscopic ovarian drilling and bariatric surgery. We will discuss each one of them one by one. Clomiphene citrate is given initially it is given 50 milligram per day for 5 days. Then if we do not get ovulation, then we give 100 milligram per day for 5 days. 100 milligram per day is a choice of regime for all the girls, and we continue this treatment for 3 to 6 cycles. If the ovulation doesn't occur, then we switch over to we call it the clomiphene resistant patient. Studies with clomiphene has shown that the ovulation rate is 60 to 85%, and the pregnancy rate is 30 to 50%. The rate of the twin pregnancy is 5 to 7%, and rate of OHS is 1%. If ovulation cannot be achieved with clomiphene citrate, then the patient is said to have a clomiphene citrate resistance. If pregnancy cannot be achieved after 6 ovulatory cycles with clomiphene citrate, then the patient is described as having clomiphene citrate failure. The certain studies has been done. It has been found that if the candidate is not able to conceive with 6 cycles of the clomiphene citrate, we should call it clomiphene resistance or clomiphene failure. Now, we have to add metformin in these girls. Metformin alone has been shown to improve ovulation and the clinical pregnancy rate, but not live birth rate. Metformin combined with clomiphene citrate has a higher ovulation, pregnancy, and live birth rate compared with clomiphene citrate alone. The studies has been done only in the clomiphene citrate resistant PCOS cases. Fertility outcomes are improved with the addition of the clomiphene citrate to metformin compared with the metformin alone in obese PCOS patients, where the BMI is more than 30 kilograms per meter square. There is no improvement in the fertility outcome when metformin is combined with laparoscopic ovarian drilling, gonadotrophic ovulation induction with time intercourse or IVF. However, metformin administration with IVF results in 70 to 80% lower risk of OHS, ovulatory hyperstimulation syndrome. Now we come to the gonadotropin. Second line of management with infertility is with gonadotropin. Gonadotropin are often used as second-line therapy in anovulatory PCOS patients where there is a clomiphene citrate resistance and where there is a clomiphene citrate failure. Recent randomized evidence suggests that the gonadotropin therapy may be more effective than clomiphene citrate therapy for PCOS women. Low-dose gonadotropin causes 70% more ovulation in pre-ovulatory patient, and there is a 15 to 20% increased chances of pregnancy. The pregnancy rate is higher in gonadotropin therapy. It has been found that to prevent the multiple pregnancy, the regime is to give the CC for 5 days, 100 milligram of CC or 5 days, and add gonadotropin from 6th day onward. In that way, we decrease the cost of the therapy, and there are decreased chances of OHS and decreased chances of twin pregnancy. But in those patients who undergo gonadotropin therapy, they need regular monitoring as there is increased risk of the multiple pregnancy and ovarian hyperstimulation syndrome. Chances of the hyperstimulation syndrome is there. So we take a low dose step-up protocol. Duration of gonadotropin therapy should not exceed 6 ovulatory cycles. Certain randomized control study trials has been done. It has been found that the low dose step-up FSH versus clomiphene citrate in around 250 women with PCOS, the FSH has a higher pregnancy rate and live birth rate as compared to gonadotropin. But there is an increased cost and inconvenient is there. So this is the second line treatment of infertility in PCOS patients. Now we come to the aromatase inhibitor. Aromatase inhibitors were proposed as ovulation inducing agent in 2001. Recently, they were, in 2005 and 2006, they were withdrawn from the market because of it was found that there was increased chances of the malformation and there is increased chances of congenital malformation. Letrozole and the anastrozole are the most commonly used in ovulation induction. Letrozole causes the increased FSH and it causes the growing of the follicle. But effectiveness of the letrozole is not better than the clomiphene citrate. There is a conflicting published data on the potential teratogenic effect of letrozole when used as an ovulation induction drug. I think this is the previous finding. Recently, the studies have been done. It has been found it has a very less adverse effect on fetus. Ovarian drilling. It is also a second-line treatment management of the ovarian ovulation induction in PCOS patient associated with infertility. Laparoscopic ovarian drilling was described first in 1984. Mechanism underpinning, and it doesn't know how it causes the ovulation induction, but it has been found that within 6 months, ovulation rate is 54 to 76%, and pregnancy rate is 28 to 76%. During the 12 months, it has been found that the ovulation rate is 33 to 88%, and pregnancy rate is 54 to 70%. So Laparoscopic ovarian drilling is recommended. It is a second-line treatment of in CC resistance and CC failure patient, and it is equivalent to gonadotropin, but it is cost effective, and it is used in those patients with a high LH value, and uh, it is very useful in those patients, those who cannot come for monitoring during gonadotropin treatment. We give to those patients who live in a far off places. They are not able to come for follicular monitoring. We do ovarian drilling when the LH level is high, and we ask them to try for pregnancy for 3 months. If they are not able to conceive in 3 months, then we call them and we give them gonadotropin stimulation. Now we come to the bariatric surgery. It is the recent development that the bariatric surgery improves the ovulatory dysfunction and improves all the parameters, like it prevents the type 2 diabetic mellitus, cardiac disease, etc. as in PCOS patient. Bariatric and weight surgery result in approximately 15 to 30% of the weight loss. A Cochrane review was done. It has been found that the more than conventional treatment with obesity, it reduces diabetic mellitus, hypertension, based on 3 RCTs, but did not assess the fertility outcome. They are not published RCTs assessing the effectiveness of the bariatric surgery, especially in PCOS patients. Recent study reported that the bariatric surgery is a potential future treatment option for obese PCOS women. The criteria is still large debatable, and more scientific research is required. Certain data has been found, and studies on bariatric surgery and outcome measurement has been found. It has been found that the biliopancreatic diversion and the Roy-and-Y gastric bypass and sleeve gastrectomy was done, and the certain parameters were studied like BMI, hyperandrogenism, abnormal menstruation, ovulatory dysfunction, hirsutism, type 2 diabetic mellitus, insulin resistance, hypertension, and the cholesterol. It has been found there is a control of all the parameters when Rao and Y gastric bypass was done. So Rao and Y gastric bypass is the preferred bariatric surgery. And third line of treatment, when the patient is not able to conceive by lifestyle modification, over-ovulation, laparoscopic ovarian drilling, and gonadotropin. Third line of treatment is IVF recommendations. So before going for IVF recommendation, we advise our patient to lose weight. Recombinant LH not to be used routinely with FSH. GnRH antagonist protocol preferred over agonist. As it reduces duration of the stimulation, it causes decreased dose of and cost. Dose is decreased when we use antagonist protocol. There is decreased chances of the OHSF. In antagonist protocol, and no fresh transfer is planned. Trigger with GnRH agonist is given when the E2 level is more than 1500, and freezing all embryos is preferred. We consider elective freeze all embryos in PCOS patient. This is the algorithm of the management of the infertility in women with PCOS. First line is a non-pharmacological management for infertility. Lifestyle intervention, as we have already talked about, is a very important, is a primary important, especially in adolescent girls. It improves the fertility, improves the confidence, it improves the menstrual cycle. And first line pharmacological management for infertility is clomiphene citrate and aromatase inhibitor letrozole. And second line pharmacological and the surgical management, like clomiphene citrate and metformin. Instead of metformin, we can give myoinositol and dichloroinositol combination. Metformin is given if BMI is more than 35, and we can add gonadotropin if follicular growth is not there. Laparoscopic ovarian drilling is done in those patients who are not able to follow and those who have a high LH. Bariatric surgery is advised only for adults who are anovulatory and have a BMI more than 35 per meter square and who remain infertile despite undertaking an intensive structured lifestyle management program for minimum of 6 months. So aromatase inhibitor is also a first line of treatment for ovulation induction. Third line management could be other appropriate intervention, as we have talked about. It is IVF management by IVF. And next come to the summary of the this thing. I think computer is hanged off. Summary is left. Summary, we have to do proper counseling of the patient, and we have to stress on the lifestyle modification. First we have to go very slowly, and we have to treat them with lot of patience. We have to advise exercise, meditation, and diet management is very important. We have to advise them follow the food pyramid. And first line of treatment is the lifestyle modification. Then we come to the pharmacological treatment. Pharmacological treatment is by oral ovulogins, aromatase inhibitor, and the clomiphene citrate. And if the clomiphene resistance and the failure is present, we can add metformin. Metformin, or in adolescent obese girl, we can give myo-inositol, dicaro, inositol. And we can do ovulation induction by taking low dose step up FSH protocol. It takes long time for stimulation, but we get a monofollicular development of the follicle, and it gives best pregnancy. We need the luteal phase support in those patients, especially if GNS agonist is given as a trigger. So, and third line of management is IVF treatment, and for metabolic syndrome, for longer, for the metabolic syndrome and lifelong this thing, health hazards of the PCOS, we have to manage diabetic mellitus. We have to advise continuous exercise, continuous weight reduction, continuous diet control is very important for long-term health hazards. So this is the recent development, the management of PCOS. Thank you very much for patient hearing. I'm really sorry my laptop is hanged and I am not able to give you the proper, but I have told you all the summary of the recent advances in the management of the PCOS. Thank you very much for patience hearing.
Thank you very much, madam, for this nice presentation. Ma'am, just give me 1 minute time to check the questions, if any, on our dashboard. Madam, one question is that in case of this ovulation induction, that is clomiphene or letrozole, which drug you prefer most?
Letrozole gives the development of the monofollicular follicle. So these days for ovulatory function, we prefer to give aromatase inhibitor, letrozole. Letrozole is given in the dose of 2.5 milligram daily for 5 days. If the follicle does not grow, we can double the dose and continue till 10th day of the ovulation. But studies further say that the clomiphene citrate is the preferred drug. Clomiphene citrate gives the multifollicular development, especially if we are inducing our patient for oral ovulogins and no IUI. So we can give them this thing, letrozole. If we are doing intrauterine insemination, then we can go for clomiphene citrate plus gonadotropin stimulation.
Thank you very much.
It gives a considerably increased incidence of the pregnancy, no doubt. But literature says that the clomiphene citrate is the preferred drug. But in my personal experience is that letrozole definitely gives very good results if we try in a patient with PCOS.
Thank you very much, madam. And madam, another question is in case of this PCOS. So maybe there are other reasons for infertility, but if you consider this PCOS and in that case, for all the patients, means on which parameters do you recommend, or means you can observe this myoinositol and dechiroinositol? Is there any other parameters that has to be taken care of, or in the normal cases for ovulation induction, prior to give this dietary supplement, and then you can go for this ovulation induction? What is your opinion?
This is a very good question. Initially, metformin was in the market, and myoinositol is a food supplement, and it decreases the LH and FSS ratio. Since it is tolerated very well, so these drugs are these days these drugs are given. These drugs are preferred for ovulation induction, especially in those patients who are obese. And this is the preferred drug of choice in adolescent obese patients. But sometimes it is not able to control the insulin resistance. So we give metformin plus myoinositol plus CC for ovulation induction in our obese reproductive age group patients.
Thank you, madam. And another thing, ma'am, in case of this insulin resistance, if some patient is having some problem with nausea, vomiting, or some stomach upset or metallic taste in case of this metformin, so what will be the drug of choice? Means so when you are not able to use this,
we give rabiprazole, we give
to suppress the complications associated with this.
Okay. Complication is associated. It is not very well tolerated. So that's why the myoinositol has come in the market. Myoinositol, dichiroinositol is a very good drug, and we have got very good results. It is a food supplement. Basically, it is a food supplement. So it's good. It has a positive effect.
Thank you very much, ma'am, for this nice deliberation. And I could not find any other question, ma'am. So if you allow me, then we can conclude this session.
Thank you very much, and thank you very much for patience hearing. PCOS is a very complicated, so there is a lot of multi-specialties involved. Because of the multi-specialty involved, there is a lot of controversy. Because of the controversy, there is a diagnostic dilemma. So we need to keep updating ourselves on this subject. Thank you very much for giving me the opportunity. Thank you all the friends to be with us.
Thank you very much, ma'am, once again for your valuable time on our platform. In future also, we look forward for some valuable session with you, madam. So thank you very much, madam. Have a good day.
Thank you.
Thank you so much, ma'am, for a nice session, ma'am.